All right, so we are discussing here a brief case scenario. So, we'll, my aim is to get the maximum discussion out of this very brief scenario here. Okay, the scenario that we have is that we have a 10-year-old child. His weight is 50 kg and has suffered an electrical current injury. He arrived in the emergency in a pulseless state. So, CPR was commenced as per protocol. So, 3 cycles of CPR has been done and 2 doses of injection epinephrine 0.01 mg per kg of 1 is to 10,000 solution IV. So it is the correct dose have been administered along with continued CPR, and rhythm has changed from figure 1 to figure 2. So what would be the next most appropriate intervention? So let's look at it. So first figure here, no pulses are felt and we have some electrical activity on the monitor. Next, it changes to this rhythm. Here we don't have any pulses and you have some chaotic, very fine waves present on the monitor. So the options that we have are, first is we continue CPR and administer injection amiodarone at 5 mg per kg over 30 minutes. Second is to continue CPR and administer injection adenosine at 0.01 mg per kg stat by the 2 syringe method fast bolus technique, which is the recommended method of administering adenosine. Or we continue CPR and plan synchronized cardioversion. And the fourth option that we have is to administer DC shock at 100 joules and act accordingly. So how should we approach this case? So first of all, it should be clear that what the common arrest rhythms and what was the scenario initially and what did it change to. So first is we had a 10-year-old 50 kg child who had suffered an electrical current injury. So he arrived at the ER in a pulseless state. That means he was in cardiac arrest. So rightly, CPR was commenced as per the pulse protocol. So 3 cycles of CPR, 2 doses of injection epinephrine already given. Dose was appropriate. Rhythm changed from figure 1 to figure 2. There we are asking what is the next most appropriate intervention. So here we are dealing with the arrest in a situation, and we have the pulseless or pulse, or and the 2 rhythms are also given. So I'll just before coming to that, usually in ICU we should be watchful and we should try to avoid such a condition. Here we have a case who are presented in the ER. So before the children go into arrest, they usually go in. If they are sick, then they might go into bradycardia or tachycardia. So just briefly, we'll just look over the bradycardia rhythm first. Whenever there is a bradycardia, that means heart rate in adults is less than 60. So heart rate is less than 60, but then we have to identify other problems, and we have poor perfusion. Sometimes in adolescent kids, the sleeping heart rate may go up even as low as 45, 50, but the perfusion is the important thing. Perfusion remains fine, then we don't need to intervene. Here, if you have a bradycardia, very slow heart rates as per the age, and poor perfusion also, say delayed CFT, altered sensorium, decreased urine output, all those things, then you look for, first you look, check the airway, give oxygen, attach monitor if already not on monitor, and recheck the blood pressure, oximetry properly, pulse oximetry properly, re-ensure the IV access, get a 12-lead ECG if available. So if the cardiopulmonary compromise continues, suppose sometimes with oxygen and all those some simple measures like bolus, these things, the heart rate might stabilize. If it doesn't, if it continues, and if the heart rate remains poor and bradycardia persists, then we might have to give epinephrine or atropine. So these two, sympathetic action and the parasympathetic. So these two act increase the heart rate. If the cardiopulmonary compromise doesn't is over, then you just support the airway, breathing, circulation, and care continue to watch the child properly. Here the doses are given. Doses remain the same, 0.1 ml per kg of a 1 is to 10,000. So the epinephrine in the vial comes in 1 is to 1,000 concentration. If IV access is not available, you can give endotracheal, but endotracheal dose is 10 times. So you can give 0.1 ml per kg of the undiluted epinephrine injection. Atropine dose is 0.02 mg per kg. If cardiopulmonary compromise, these are the signs: hypotension, altered sleep, I just told you. Second thing is tachycardia with pulse rhythm. Here, if the heart rate is increased for the age, then you do the basic measures: airway, oxygen, IV access, bolus if needed. Look for signs of shock. Then you evaluate QRS duration. If the poor perfusion is persisting, shock like state is persisting. So QRS duration is less than 0.09 second. Then we have to differentiate between sinus tachycardia and supraventricular tachycardia. Usually, most commonly it's sinus tachycardia, but we should be able to identify the supraventricular tachycardia also if the rhythm is wider, more than 0.09 second. This is based on the QRS duration. I have other videos on this channel where you can go through in detail how to evaluate these durations and what are their implications. So possible ventricular tachycardia, if it is wide means it's coming from this, originating from below the normal the impulse pathway, sinoatrial pathway. So here again here actually we are discussing is because the management differs, and one variant of it comes into the arrest rhythms also. So here we have to give adenosine. Here also we have to give adenosine and synchronized cardioversion here. And the doses are here are given. They'll just can go for synchronized cardioversion. The dose of current is less, 0.5 to 1 joule. For defibrillation, dose is 2 joules per kg. You start with 2 joules per kg, and if it continues, and if you have looked for the hypoxemia, hypertension, hypothermia, all those 5H and 540s, you have ruled those out, then you can give amiodarone and amproquinamide, but they usually practically very rarely required. So suppose you have a tachycardia with poor pulse and you have this type of rhythm. Here you can it's a if you will be able to enlarge it, or if you know that the QRS that's more than 3 small squares, one small square is 0.04. So it is wide. Definitely it's I think 0.12 around, so definitely wide, more than 0.09. It's a wide complex tachycardia. Usually it's a ventricular tachycardia. Here the further management will depend upon your pulse or not. If it's a pulseless condition, then you will treat it differently. But with pulse, then you cannot defibrillate. You have to continue with your measures. You can give medicines, you can give synchronized cardioversion, you can give adenosine. And this, so 1 second here. So one more rhythm here. What is this? So you can go into the other lectures. Here you have a very fast heart rate, and you P waves are not clearly visible, and RR interval is fixed. So it's a supraventricular tachycardia. So here the treatment is different. Here again vagal maneuvers and synchronized cardioversion if it doesn't resolve. But first you can try adenosine, which is the treatment specific treatment for this, because it will cause a block at the junction. So that will take care of it. Now let's come to the final thing which we were discussing is what the scenario that we have was what cardiac arrest. Child was already in arrest, and you already started CPR. So the current latest algorithm is this: you start CPR if the rhythm is shockable or not. That is the main question. So here initially the child had pulseless electrical activity, which was not a shockable rhythm. The child was pulseless, but there was activity on the monitor. So it was one of these things, histosol or PEA. So here again, first epinephrine. Now we should start with epinephrine as soon as possible. Give CPR for 2 minutes and continue to repeat epinephrine every 2 to 3 minutes and continue to check for the rhythm. Whenever it becomes shockable, then you give shock. You go to 7 and give shock. If the rhythm is shockable, so there are only two shockable rhythms. Either it's ventricular fibrillation or the other is pulse less ventricular tachycardia. So why we cannot give is whenever there is pulse, that means some inherent cardiac output is there and cardiac rhythm is being generated. Some PQRS waves are being generated. There is atrial systole, there is a ventricular, there is a coordinated contraction is there. If you give defibrillation, then the heart can go into fibrillation itself, because that in such a condition, if you have a pulse with VT with pulse, you do synchronized cardioversion where you try to synchronize the current administration to the R wave so that the contractions coincides. If we do not synchronize properly, then that pulse VT with pulse can convert into ventricular fibrillation or pure asystole, something like that. That could be detrimental. That is the basic thing. So the only two shockable rhythms, again I am repeating here, ventricular fibrillation. Ventricular fibrillation, the heart is just quivering, ventricles are just quivering, they are not contracting properly, so the getting a pulse is practically not possible. So if you have that type of activity on the monitor, that you know that you are dealing with fibrillation, that is one indication of defibrillation. There you start with 2 joule per kg. So if we had a 50 kg child, you start with 100 joules. So option D was the correct answer. You give 100 joules and continue CPR and epinephrine as per the protocol. This is the PQRS normal rhythm. Here the activity has been because the normal pathway from the pacemaker to the through the atria through the interventricular junction that is not there to the through the bundles. So here ventriculars are contracting independently and these are not effective. That's why we have to defibrillate here along with CPR. CPR must continue at all times. So briefly in two slides, the 2020 changes or some additions or a summary of the pulse update from the 2020, that some changes. So assisted ventilation rate has now increased. So now you have to give one breath every 2 to 3 seconds. So instead of 10 to 15 breaths per minute, you will now have to give a slightly higher rate, 20 to 30 breaths per minute. Cuffed endotracheal tubes are preferred because can deal with higher ventilation pressures better. Routine cricoid pressure while intubating is not recommended. As we just discussed, epinephrine as soon as possible should be given whenever a arrest scenario is identified. If you have an arterial line in place, you can use the feedback from the arterial line. You will get some good tracings. You can detect return of spontaneous circulation and effectiveness of your CPR contractions. Post return of spontaneous circulation, neurological evaluation is very important, especially the risk of seizures is very high because of anoxia hypoxic injury. So that should be there, and a wholesome care should be provided. Psychological, physiological, physical fluids as needed should be given in such conditions, and vasoactive agents depending upon the physiology, whether epinephrine is or norepinephrine should be given. Balanced blood component resuscitation is recommended in hemorrhagic shock. If a opioid overdose situation is led to this condition, this arrest scenario, then CPR plus naloxone should be used. Whenever there is a acute myocarditis or acute low cardiac output state, then early ICU care is recommended because they might need early mechanical ventilation and mechanical support, circulatory support like extracorporeal life support, ECLS. Special considerations are required in congenital heart disorders, especially with single ventricle physiology, where the normal pathways of the venous return output from the heart are little impaired. And targeted management of pulmonary hypertension should be done because pulmonary hypertension can progress very early and can lead to an irreversible cardiac output state. Okay, so these were the few summary main points. So the learning points here basically are you should first of all recognize arrest early, differentiate when to do CPR and to when to do CPR plus defibrillation. Defibrillation alone is almost never done, so CPR always is continued. Current dosage should be clear. For synchronized is 0.5 to 1 joule per kg. For defibrillation it's 22 joules per kg, then for 4 joules per kg, then you keep increasing it, and stay up to date with the latest pulse algorithms and follow this.